Assalamu alaikum, good morning. Welcome to you all to my today's topic, MINOCA, that is myocardial infarction with non-obstructive coronary arteries. This is Dr. C.M. Khuda, Assistant Professor Cardiology and IPDI. Case vignette. Mr. X, 73 years old, severe compressive central chest pain and shortness of breath for 6 hours. Risk factors are diabetes mellitus, hypertension, and ex-smokers. ECG was done, and there is T inversion in 2, 3, and ABF. Investigation profile was done, and troponin I was raised and positive. Echocardiogram was done and showed there is severe LV systolic dysfunction and ejection fraction is 30%. And then the MPI was done, and it revealed that fixed perfusion defect is seen in LCX territory. Then we went for angiogram, and it shows that left main is normal, LED is normal, and LCX is normal too. And for the right side, right coronary artery is normal too. So my diagnosis is non-ST elevated myocardial infarction with severe LV dysfunction with CG showed normal epicardial coronary arteries. So the diagnosis is MINOCA. We all know that ischemic heart disease comes with stable coronary syndrome and acute coronary syndrome. And the ischemia with non-obstructive coronary arteries is consistent with stable coronary syndrome, and MINOCA is consistent with acute coronary syndrome. And it's amazing that what we can see is only 5% of total coronary tree in angiogram. Now, what's MINOCA? MINOCA is a syndrome with different causes characterized by clinical evidence of MI with normal or near normal coronary arteries on angiography. It represents a diagnostic and therapeutic dilemma since many patients are discharged without a clear etiology for the clinical presentation. MINOCA can present with ST elevated MI approximately 1/3 and non-ST elevated MI approximately 2/3. The diagnosis of MINOCA is made immediately upon coronary angiogram in a patient presenting with features consistent with an MI as detailed by the following criteria. Universal AMI criteria, non-obstructive coronary arteries on angiogram defined as no coronary artery stenosis more than or equal to 50% in any potential infarct-related artery, no clinically overt specific cause for the acute presentation. Data from large MI registers suggest a prevalence between 5% to 25%, but the most recent study in a contemporary cohort of patients revealed a prevalence of 8.8%, which appears to reflect daily clinical experience. Patients with MINOCA are often younger, more likely to be women, and less likely to have dyslipidemia. Potential mechanisms are plaque disruption, vasospasm, dissection, thromboembolism, microvascular dysfunction, and supply-demand mismatch. Investigations, those are clinical history, ECG, echocardiogram, cardiac biomarkers, coronary angiogram, and left ventriculography to diagnose the Takotsubo syndrome. And if there is suspected unstable plaque, IVAS, OCT can be done. If there is suspected functional coronary artery alteration, intracoronary acetylcholine provocative test could be done. And if there is suspected myocarditis, CMR with CM and endomyocardial biopsy could be done. And if there is suspected microembolism, transesophageal echocardiography or contrast enhanced echocardiography could be done. And you know that CMR imaging is a key investigation in identifying the underlying cause. Recent reports claim that CMRI identifies the underlying cause in as many as 87% of patients with MINOCA. That is AMI 28%, 4% of AMI, 33% of myocarditis, and 18% of Takotsubo cardiomyopathy can be diagnosed by cardiac MRI. And then the treatment and management of MINOCA is based on limited evidence, and there are no prospective randomized control trials. Medications such as aspirin, statin, beta blockers, clopidogrel, AC inhibitors, and ARB should be considered on the basis on the underlying mechanism for the MINOCA in each individual. If there is any evidence of atherosclerosis, modifiable coronary artery risk factors should be treated aggressively. Coronary vasospasm is best treated with calcium channel blockers. And now the predictors of outcome. Studies of MINOCA prognostic risk factors are minimal, and it's not clear if they differ from MI coronary artery disease predictive risk factors. The ACUITY trial indicated that elevated cardiac troponin is associated with increased mortality in MINOCA, and the CAMI NIH study concluded that in MINOCA patients, old age, ST elevation on ECG, KILIP class 4, and diabetes were independent predictors of all-cause death at the 2-year follow-up. Thank you all. Thanks for patience hearing. We are celebrating the 102nd birth anniversary of Bangabandhu Sheikh Mujibur Rahman and celebrating 50 years of independence.